So what are inborn errors of metabolism? These are monogenic disorders, and majority of them are inherited as autosomal recessive traits. They're individually rare, but collectively they are numerous. There's extensive spectrum in the phenotype, and that's because of complex interactions of involved proteins and the genetic and environmental modifiers. And we try to lump the inborn errors of metabolism into three big categories based on the mechanisms of the pathogenesis. Either it is because of toxic accumulation of metabolites, or it could be because of disorders of energy metabolism, or disorders of the complex molecules. So going a little bit into the toxic accumulation of metabolites, some of the disorder categories that can be included in this group would be organic acid disorders, the urea cycle disorders, which are also amino acid disorders, but a special category. Then the general amino acid disorders like phenylketonuria, homocystinuria, some intolerance of the sugars and carbohydrates like galactosemia, fructose intolerance, and also intoxication because of metals like Menkes, Wilson's disease, hemochromatosis. And in general, the presentation has no effects on on fetal development, so they're born normally with no outward features suggestive of an inborn error of metabolism. And then they might present with an acute overwhelming illness or recurrent episodes of deterioration in the condition, and also with some of them might have some chronic clinical signs of intoxication. These disorders do have some triggers for acute crises, such as an illness, catabolic state, fasting, or excessive protein intake can trigger an attack. The next group of disorders is the disorders of energy metabolism, and we divide them further into those that are because mitochondrial disorders, which includes the fatty acid oxidation defects and respiratory chain disorders, to name a few. And then also the cytoplasmic disorders, which would include disorders of glycolysis, glycogen metabolism, gluconeogenesis, creatine metabolism, and so forth. In these disorders, some malformations or dysmorphia might be present even at birth, but not compared to some of the other groups of disorders. The presentation could be acute or progressive or chronic. And the systems mostly involved are those that like liver, muscle, and brain, which are tissues with high energy requirements or are the source of production of the energy. They present with episodes of hypoglycemia, lactic acidosis, hepatomegaly, hypotonia. These are some of the features that are seen with these conditions. And again, like with the toxic intoxication conditions, they can also be triggered by the acute crisis can be also triggered with things like illness, catabolic states, fasting, exercise, fructose, and so forth. And the final group is disorders involving the complex molecules. These involve disorders of cellular organelles that disturb the synthesis or catabolism of the complex molecules. These disorders are further divided into multiple groups. The lysosomal storage disorders, which can be further divided based on the substrate that's accumulating, the peroxisomal disorders like X-linked leukodystrophy, the Zellweger spectrum disorders, and then finally there are disorders of intracellular trafficking and processing, which include disorders of glycosylation, disorders of cholesterol synthesis. In these, the clinical presentation is more complex and the diagnosis is a little more difficult to make. They could have malformations and dysmorphia might be present right at birth, or they have permanent progressive symptoms that are independent of intercurrent events or any dietary intake. So let's start with a case. A full-term baby is born, uncomplicated deliveries, doing well at time of discharge at 36 hours of life. He's breastfeeding well. On day of life 4, he presents with he's noted to have decreased interest in feeding and is sleeping more than usual. On day of life 5, his condition has worsened and he's unarousable at times, and his breathing is a little unstable as per the parents, and he's brought to the emergency room. When he's brought there, he's upturned and tachypneic. He's afebrile, and looking at his tone, he has axial hypotonia, but he's hyperreflexic and appendicular hypotonia is present. So this is a typical acute presentation of an inborn error of metabolism, and when faced with a acute presentation like this, most individuals would think of an inborn error of metabolism. And some of the investigations that need to be done right away, I've divided into two groups, the routine and the special metabolic ones. In the routine ones, like blood glucose, electrolytes, liver function tests, ammonia, lactate, CK, uric acid, the pH, and the urinary ketones, they're available within a few hours and available in most hospitals. And this set of labs will help us decide to peg the disorder in a particular category and start the initial management. The special metabolic labs like the plasma amino acids, plasma acylcarnitines, the urinary organic acids, and CSF, if it's done, the results are going to take a little longer. They might help us pinpoint the disorder, but they may not even help us with the immediate management. Once we've suspected an inborn error of metabolism, the first thing we need to do is start the child on 10% glucose infusion. And the general rate recommended is 10 milligrams per kg per day, which is equivalent to the normal hepatic production. At this rate, it's sufficient. This rate is sufficient for disorders with reduced fasting tolerance, such as the glycogen storage disorders or the fatty acid oxidation defect. This may not be sufficient for disorders such as the urea cycle defects and organic acid disorders, but it is an initial start. And it might be excessive for some mitochondrial disorders, but over time and with the initial few labs, it would give us an idea of whether we need to reduce this rate or continue at the same or increase it further. So once we get the results back on the first set of labs, we're looking specifically for certain biochemical abnormalities, such as metabolic acidosis, hypoglycemia, hyperammonemia. In this particular neonate, there was significant metabolic acidosis with ketones, which after going through our algorithms, you can see that the most common presentation with increased acidosis, ketones, glucose not significantly elevated would be the classical organic acidemias, in which propionic acidemia, methylmalonic acidemia, and IVA are the common ones that you might have heard of. So what are organic acidemias? And we like to divide the organic acidemias into two different categories further. One are the classical ones, like the case presented, and cerebral organic acidemias. In the classic organic acidemias, the metabolic abnormalities are present, and the systemic involvement other than neurological also is present. As I mentioned them before, propionic acidemia, methylmalonic acidemia, isovaleric acidemia are some of the ones that are the most common. Then you have the cerebral organic acid disorders, in which the metabolic derangements are absent, and the presentation is exclusively neurological. One of the examples of that is the glutaric acidemia type 1. And I have maple syrup urine is also considered an organic acid disorder, but it can also be classified as an amino acid disorder. This slide shows that the small molecules, the metabolic pathways of the small molecules are very closely interlinked. And the amino acids, once they release the ammonia, which goes into the urea cycle and is eliminated that way, the leftover portion of an amino acid is an organic acid, and that it's interlinked to the other pathways. Any metabolic pathway, a metabolic block that results in the accumulation of organic acids is an organic acidemia, and most of them come from metabolism of the amino acids. The classic organic acidemias that we discussed are all blocks in the pathways of the branched-chain amino acids, the MSUD, the IVA, the propionic acidemia, and methylmalonic acidemia. So what is the presentation of the organic acidemias? The acute presentation, the one we described, that acute neonatal presentation is present in about 2/3 of the classical organic acidurias. And the presentation is quite non-specific. With the clinical findings can be confused with many other overwhelming illnesses like infections. they start non-specifically. There's poor feeding, vomiting, there could be lethargy, can rapidly progress to coma. There might be some abnormal tones, abnormal breathing. They could even start having seizures. And the severity and onset varies depending on the severity of the block. And then we have a non-acute presentation, which would be, again, can be quite non-specific with failure to thrive. You can have chronic or cyclical vomiting. You have recurrent infections because of suppression of the bone marrow. Then recurrent pancreatitis can be present. Some of them might have cardiomyopathy, especially this is common in long-standing propionic acidemia. You could have renal disease. Some of the disorders can present with unusual odors, burnt sugar or maple syrup in the maple syrup urine disease, or sweaty feet as in isovaleric acidemia. And then neurological manifestations are very common presentations of quite a few inborn errors of metabolism, and especially the organic acidemias. And the neurological complications could be non-specific, again, like development delays and seizures, or they could be just hypotonia, metabolic strokes, which could be acute or progressive, have been reported, and optic atrophy and retinitis pigmentosa is also common with the organic acid disorders. We already discussed some of the acute management, which is starting the high-dose glucose, but in that we had started at maintenance at the initial step. Now we need to bump it up to 1.5 times the dose discussed. At this stage, a child should not really be taking protein, but if for any reason the child was taking formula, we need to stop the protein intake completely, because as I mentioned, most of these disorders are because of blocks in the in amino acid metabolism. Hemodialysis could be required in order to get rid of some of the toxic metabolites, like propionic acidemia. Carnitine helps mop up the organic acids, and that's given. And the vitamins that could be cofactors for the enzymes are also useful. The long-term management is dietary therapy, which includes we reduce the intake of the offending amino acid by restricting the total natural protein while maintaining a sufficient intake of essential nutrients and energy substrates using specialized formulas. And we can give carnitine and cofactors, as mentioned previously, and the early aggressive treatment of intercurrent illness, managing the metabolic crisis as described previously, and treatment of manifestations when they arise. Then we have the cerebral organic acid disorders. I've already mentioned that the metabolic abnormalities are generally absent, and the elevation of diagnostic metabolites could be very minimal, and they have non-specific neurological symptoms, hypotonia, macrocephaly, epilepsy, and so forth. The one I want to mention here is glutaric aciduria type 1. One because it's detectable by newborn screening now, but also it has been confused with trauma and child abuse. It presents, 50% of the individuals with the disorder could have macrocephaly at birth, and some neurological findings as they get a little older, but generally an acute encephalopathic crisis occurs at about 3 to 18 months of age. It could be precipitated by an intercurrent illness, but cases have been reported where there might be nothing obvious. And then depending on the damage caused by the encephalopathic crisis, you have subsequent either dystonia, significant motor disabilities, and everything. As I mentioned, that these individuals could have subdural hematomas or hygromas, and that's why they have been confused with trauma or child abuse. The same presentation we discussed before. Now, if we checked the biochemical abnormalities and we found the child had significant hyperammonemia, we would suspect a urea cycle defect. There are other causes of ammonia being elevated, but in general, the ammonia levels will not be as high as they're seen with the urea cycle defects. The other causes could be systemic illness, any systemic illness, liver failure. And another reason we have to be really careful with ammonia is that any delay in sample analysis can lead to elevations of the ammonia. Other inherited disorders would be organic acid disorders and fatty acid oxidation defects, but generally not as high as ammonia as you see in the urea cycle defects. So This diagram shows how the ammonia is ammonia in the body pool is eliminated in the form of urea. There's multiple steps that take place, multiple reactions which take place both in the mitochondria and in the cytosol, and there are some enzymes, there are some transporters that are required to transport the substrates from one compartment to the other. Any block in any of these pathways or transporters can lead to a urea cycle defect, and resulting in the elevation of ammonia. And in most cases, the arginine is decreased except in arginase deficiency. The pattern of abnormalities of the amino acids gives us an idea of where to pinpoint the block. The most common one is the OTC deficiency, which is an X-linked disorder. And any disorder that is, any block that is beyond the synthesis of carbamoyl phosphate leads to increase of carbamoyl phosphate, which goes into an alternate pathway and results in the increased secretion of orotic acid, and that's the reason why this marker is helpful in diagnosing the urea cycle, distinguishing some of the urea cycle defects. So what is the presentation? As with the organic acid disorders, about 2/3 of the cases present with an acute neonatal presentation. There are some intermittent and milder forms which could present just with episodic headaches, ataxia, sleep disturbances, psychosis. One particular disorder amongst the urea cycle, the arginase deficiency, is less likely to have an acute presentation. It more commonly presents with progressive spasticity. The overall incidence of all these disorders together is about 1 in 30,000, and all of them are recessive except the OTC deficiency, which is X-linked, but about 15% of the females with OTC deficiency also can present with hyperammonemia. Many of them present later in life or during postpartum or when there's with the increased protein intake. So treatment, as again with the other group of disorders we discussed, you have to treat the acute symptoms first. Acute treatment of hyperammonemia involves using IV nitrogen scavenger drugs. Dialysis might be required to control the ammonia, to bring the ammonia levels down, and then you supplement with arginine and citrulline, or depending on the disorder. Most of them do require citrulline or arginine, except the arginase deficiency. The long-term management requires restriction of the protein, which reduces the amount of nitrogen in the system, and use of specialized formula to make up for the nutritional deficiencies. The IV scavenger drugs, instead of that, now we give oral nitrogen scavenging drugs, and again supplementation with the arginine, citrulline, depending on the disorder. And we have to avoid certain medications like valproic acid, intravenous steroids, which can suppress the urea cycle further, and prolonged fasting needs to be avoided. Oops. So this is the same chart. This diagram shows how the two nitrogen scavengers, phenylbutyrate and benzoate, bind with some of the amino acids and are released into the urine as other compounds. So urea cycle disorders is one group of amino acid disorders, but there are plenty of disorders. I will not go into all of them, but I've just mentioned a few. The phenylketonuria, which everybody is aware of, which was one of the first disorders to be screened for, and untreated it can cause progressive psychomotor retardation, seizures, spasticity. You can have a mousy odor with it. Homocystinuria, which can present with ectopic lens dislocations, some marfanoid features, thromboembolic events, and untreated can cause mental retardation and seizures too. Tyrosinemia type 1, again, is part of newborn screening now in most states. It presents with hepatic dysfunction as early as the 3rd week of life. Also have renal tubular disease, coagulopathy, and one of the markers that's elevated in it is alpha-fetoprotein. It helps us. Non-ketotic hypoglycemia can present with neonatal seizures and a severe encephalopathy. And serine deficiency I've just mentioned because it's one of the new group of disorders that's being diagnosed now, and they can have microcephaly, psychomotor retardation, seizures, and if it's diagnosed, treating with serine is very, very helpful. So let's go on to another case. This is a full-term born doing well at time of discharge breastfeeding. Screening results that become available on day of life show that it's positive for galactosemia. The total galactose is reported to be 40 milligrams, which is much above the cutoff of 14, and the GALT activity is 3% of normal. When evaluated by the physician, the mother reports a history of poor feeding for about a day, and the baby looks slightly jaundiced. The breastfeeding is discontinued appropriately, and the baby is switched to soya-based formula, galactose-free formula. He's admitted into the hospital for observation, and the initial lab shows serum bilirubin of 12 and mild elevations in the liver function test. The urine is tested for reducing substances, and they're positive. So this was a presentation of a galactosemia, nearly asymptomatic baby who presents because of screening. Galactosemia is one of the disorders that's detected because of elevated galactose in the blood, and the defect for the classical galactosemia is at the level of GAL1P uridyl transferase and results in accumulation of GAL1 phosphate and total galactose. The frequency is reported to be 1 in 60,000, and the diagnosis can be confirmed by testing the GAL1 phosphate in the erythrocytes. You can take the urinary galactose, which is an alternate pathway that comes into play when the galactose is elevated. You can confirm the enzyme activity in the blood RBCs instead of the dried blood spot that was the newborn screening, and we can also do GALT gene mutation analysis. So classical galactosemia, the symptoms start after after the introduction of galactose. Progressive symptom, it's presents in the neonatal period generally with hepatic dysfunction, can progress on to renal tubular disease, and E. coli sepsis is common in this untreated galactosemia. Cataracts could also be present, and those who survive would have development delays and mental retardation. Individuals, even who are treated, do have primary ovarian failure, and the treatment really is a galactose-restricted diet for life. With newborn screening, we are finding a lot more of a duodenal variant of galactosemia, which does result in a decreased activity, but the activity is sufficient enough that these individuals do not require treatment. Prior to newborn screening, most of these individuals probably were not even picked up by screening, by clinical presentation. Moving on to a next case, we have a 15-year-old male who presents with dark-colored urine and muscle pains of 5 days duration. And he gives a prior history of dark-colored urine and muscle aches after activity, which with the initial episode occurred about 7 years of age and has happened now every 2 to 3 years after that. He reports that the current episode followed about 2 to 3 hours of sledding and playing in the snow. Physical examination is quite unremarkable except for slightly elevated blood pressure of 152/83. His mucous membranes were a little dry, and his extremities had some generalized tenderness. But the initial lab investigations reveal an extremely elevated creatinine kinase of greater than 15,000. And he's treated as rhabdomyolysis with hydration with fluids, and he improves over time. And the diagnostic labs that was sent at the time do come back and show an elevation of the carnitine C14-1, C14, and C14-2, and the pattern is consistent with VLCAD. So what is VLCAD? VLCAD is one of the common fatty acid oxidation defects. So what are fatty acid oxidation defects? Fatty acid oxidation takes place in the mitochondria, where in one cycle, one fatty acyl coenzyme A gets converted to another fatty acyl coenzyme, which has 2 carbons less than the initial one. And at the same time, you also synthesize a 2-carbon acetyl coenzyme A. So in each cycle, you keep reducing the number of, you start getting shorter and shorter fatty acids. This requires a series of steps, but the interesting thing is that the enzymes involved are very specific for the chain length, the number of carbons in the fatty acid. So you have a set of enzymes that acts on the long-chain fatty acids. We have a set of enzymes that acts on the medium-chain fatty acids, and then finally on the short chains. The long chains also, to get into the mitochondria, they require to bind with carnitine, and there are a few steps involved in it. Any defect which disrupts the activity of the beta oxidation and results in decreased synthesis of their energy through fatty acids is a fatty acid oxidation defect. The defects can be because of enzymes directly involved in the beta oxidation, which includes the very long-chain fatty acids, a very long-chain acyl-CoA dehydrogenase deficiency, like the example we gave before, the trifunctional protein complex deficiency, the long-chain hydroxyacyl-CoA dehydrogenase deficiency, and the most common of them, the medium-chain acyl-CoA dehydrogenase deficiency. Then disorders of the carnitine cycle and electron transport also result in decreased fatty acid oxidation. The diagnostic studies, as I mentioned, the plasma acyl carnitines. We can also check for urinary acyl glycines, urinary organic acids. They can also be confirmed by molecular analysis and enzymatic studies on skin fibroblasts. Earlier, when molecular analysis was not easily available, enzymatic studies were the ones that were used more often. So what are the clinical presentations? We described one clinical myopathic presentation with rhabdomyolysis, but the symptoms with the fatty acid oxidation defects can be triggered by catabolic states like illness or fasting, basically when your energy demands are increasing, like with exercise. The spectrum there's a wide spectrum, and you could have a presentation that's severe that involves all the tissues which require a lot of energy, such as so you can present with hypoketotic hypoglycemia because of liver involvement, hepatic encephalopathy. You can have cardiomyopathy. These can be acute episodes, but if they continue, you can have permanent damage to the tissues too. And then there are some which are purely hepatic, where you have episodes of hypoketotic hypoglycemia with hepatomegaly, and that resolves completely between episodes. And then the myopathic picture that we described before. So just a few words on two disorders. The MCAD, because it's the most common disorder, and this disorder primarily has only episodes of hypoketotic hypoglycemia and hepatomegaly. It doesn't have a chronic presentation like can be seen with the long chain defects. Then you have trifunctional protein deficiency and LCHAD that can present as maternal HELP syndrome. So if a fetus has this particular condition, the mother can present with HELP syndrome in her pregnancy. Another thing is that these individuals do have progressive neuropathy and retinopathy does not even seem to respond to treatment. So what is the treatment? Is giving a low-fat diet, so you don't need to use too much of the fatty acids and prevent accumulation of then the avoidance of fasting and prolonged exercise. We give uncooked cornstarch, which is a slow-release form of glucose. In the long-chain fatty acids, we can give medium-chain triglycerides because they bypass the pathway completely because they require a different set of enzymes, which are lower in the pathway. Carnitine, especially for carnitine deficiency. And for certain disorders, we can give riboflavin. If an individual is going to exercise, we suggest glucose supplements before and after. There are some trials going on with triheptanoin and benzofibrate. Another case is a progressive multisystemic disorder. There's a 9-year-old female who presents with recurrent headaches of 6 months duration. But this prompted a visit to the hospital because of her transient loss of vision with this particular episode. Initial examination is unremarkable, except that she is slightly short at 10th percentile and is diagnosed with migraines and sent home. Over the next few years, she continues to have intermittent episodes of coma, blindness, seizures, paralysis, and she's also developed deafness and cardiomyopathy. Workup is completed, and she's diagnosed with mitochondrial encephalopathy with lactic acidosis and strokes, and that is Miller syndrome was diagnosed. So what are mitochondrial disorders? We already talked about some fatty acid oxidation taking place in the mitochondria, but mitochondria are real energy boxes of the body. There are lots of other enzymes working there. So any defect which impairs the normal functioning of the mitochondria, can results in a mitochondrial defect, and it could be either because of specific enzyme defects or in the number or structure of the mitochondria itself. So the overall incidence of the mitochondrial disorders is quite high, though making a diagnosis can be difficult, and many of them probably go undiagnosed, about 1 in 5,000 to 1 in 8,000. And the defects could be because of mutations in the nuclear genes, which might affect the enzymes itself, or the complex assembly, complex 1, 2, 3, mitochondrial biogenesis and replication, which leads to less number of mitochondria, abnormal mitochondria. And these disorders could be dominant, recessive, or X-linked. And then we have mutations in the mitochondrial DNA itself, which could be either small mutations or large mutations. And these the inheritance is the maternal inheritance, which is typically associated with mitochondrial disorders. So here I list a few examples of the mitochondrial disorders. MELAS is the one we already discussed, the myoclonic epilepsy, lactic acidosis, and stroke, which is due to a point mutation in the mitochondrial DNA. Then another common one is Pearson syndrome, in which you have anemia because of marrow failure. You can have lactic acidosis, exocrine pancreatic failure, and renal tubular acidosis. Another one is maternally inherited deafness. This is the one that causes deafness because of exposure to aminoglycosides. Again, this is due to a mitochondrial DNA mutation. But important thing to remember is that many patients do not present with a classic phenotype. And so anytime we have symptoms suggestive in 2 or more systems, it's important to consider the mitochondrial disorders. It's a multisystemic involvement and affects tissues with high energy demands, and the phenotype can vary with age. This slide lists some of the suggestive findings. As you can see, it involves most systems. Some of the things that point towards mitochondrial disorder would be retinitis pigmentosa, ophthalmoplegia. You could have exercise intolerance, conduction defects, dysmotility, Fanconi syndrome, and so forth. So how's the diagnosis made? As I said, it's a little difficult, but some of the and it's not always clear-cut, but some of the things that we use is the biochemical test might show elevation of lactate, pyruvate, alanine. MRI findings can sometimes be suggestive of a mitochondrial disorder. Liver and muscle biopsy might show specific findings of either less number of mitochondria, abnormal mitochondria, some muscle fibers, abnormal muscle fibers like ragged red fibers, or defects in the COX proteins. Enzyme defects can be, enzyme assays can be performed on muscle, liver, fibroblasts, and DNA analysis for mitochondrial and nuclear mutations can be performed. Treatment is not very good for most of the mitochondrial disorders, and it can be non-specific, that you treat the symptoms for the involved organs. And we try out some supplements with carnitine, coenzyme 10, riboflavin, antioxidants, and some dietary modifications can be done. Like, for example, a ketogenic diet can be tried for pyruvate dehydrogenase deficiency. So again, going forward with other progressive multisystemic disorders, this is a 2-year-old female who presents with developmental delay, progressing developmental delay, and snoring. Physical examination reveals some coarse features. She has some corneal clouding. She has liver enlargement, and she has a gibbous deformity of the spine, which is this humpback in the region. This X-ray, this MRI finding is not for this of this patient, but I'm just showing you as an example here. So this brings forth the group of disorders which are the lysosomal storage disorders. Lysosomes are organelles that are required for cellular turnover, and they contain more than 50 enzymes that are required for the metabolism of macromolecules. And a deficiency in any particular enzyme, a specific enzyme, results in the accumulation of the substrate, which causes progressive cellular and organ dysfunction. And the disease phenotype will depend on the type of substrate and the site of its turnover. And disease severity will correlate with the amount of residual activity in most cases. And incidence as a group is quite high, 1 in 7,000 to 1 in 10,000. Most of them are autosomal recessive, except for Fabry's, MPS II, and Danon disease, which are X-linked disorders. So what should point us towards a lysosomal storage disorder? Coarse facial features like shown in this child here, enlargement of the liver, spleen, eye abnormalities such as corneal clouding, cherry red spots, optic atrophy. These are findings that can be seen with the lysosomal storage disorders. Some skeletal abnormalities such as decreased range of motion, you have a claw hand, and dysostosis multiplex on the X-ray, which is basically on multiple. This one shows an example of a bullet-shaped phalanges in a hand, and some non-immune hydrops could suggest like lysosomal storage disorders. I've listed here some examples, very few examples, but some of the ones that I've listed here are some that are being considered for newborn screening and might be available in some of the states already or would be available pretty soon. Gaucher's disease is one of the most common disorders in the lysosomal storage disorders. The substrate accumulates in the macrophages, and you see hepatomegaly. You can have lytic bone lesions. You have progressive neurological disease in type 2 and 3. Then you have Krabbe disease, which is hypotonia, irritability, loss of milestones, could be some of the clinical findings initially. It's a white matter disease. MPS I was a case we described before, which is a tissue that's accumulating the substrate is a connective tissue. And Fabry's is the accumulation occurs in the vascular endothelium, so you can have peripheral neuropathy because of that, angiokeratomas, and late renal and cardiovascular disease. And Pompe disease is accumulation in the muscle, and so it has the classical form presents with cardiomyopathy and severe myopathy. So how do we make the diagnosis of the lysosomal storage disorders? The urine mucopolysaccharides and glycoproteins, which the complex molecules, they can be tested in urine, but it's not always diagnostic, but it's a good screen. The lysosomal enzymes can be tested directly in the serum, leukocytes, or fibroblasts, and molecular analysis is also is available. We do have some of the bone marrow or blood spear might show some vacuolated lysosomes that might give us an idea. And you have the X-ray findings might be helpful, and ophthalmological exam might be helpful. So what's the treatment for the lysosomal storage disorders? Enzyme replacement is available for some of them, especially the ones that are being considered for newborn screening, the Gaucher's, Fabry's, Pompe's, MPS. And in some cases, stem cell transplantation has been used, especially for the cerebral forms of the disorder. Another group of disorder, because the organelles, is the peroxisomal disorders. Like the lysosomes, they're present in most cells except the RBCs. There could be several hundreds per cell, and they have more than 70 enzymes in the matrix. And the disorders could be either because of defect in the synthesis of the peroxisomes itself, which will result in multiple deficiencies of multiple enzymes and cause the whole picture, or it could be a single enzyme defect or a transporter defect. There are at least 13 disorders, but the most common one is the X-linked Adrenoleukodystrophy, which I'll talk a little bit about. So what is X-linked Adrenoleukodystrophy? It is one of the most common monogenic forms of inherited neurodegenerative disorders. It's an X-linked disorder, and the prevalence is about 1 in 21,000. Even some females, heterozygous females, present with symptoms, and the combined prevalence is around 1 in 16,800. The disorder primarily affects the nervous system. You can have spinal tracts and the brain, and also the adrenal cortex. So the cerebral So as I mentioned, it can either affect the brain, causing the cerebral adrenoleukodystrophy, or you can have affecting mainly the spinal cords, which is the adrenomyeloneuropathy. You have in the cerebral ALD, the initial symptoms might generally present after 2.5 years of age, and they are often misdiagnosed as ADHD. Could be mild behavioral abnormalities, and then over time it progresses rapidly, and you have progressive behavioral, cognitive, neurological deficits, and progresses finally to a vegetative state. And the death can occur within 2 to 5 years after the onset of initial symptoms. The penetrance for this form of the disorder is about 35 to 40% in males presenting in childhood. All individuals who do not die of the cerebral form of ALD in childhood would eventually develop the second form, which is the slowly progressive axonopathy affecting both the sensory and the motor spinal cord tracts. And in some cases, you can have a peripheral neuropathy too. For this particular disorder, the symptoms generally present between 20 to 30 years in males, and in females by 40 to 50 years of age. And this initially can be misdiagnosed as multiple sclerosis or spastic paraparesis. So how are these disorders diagnosed? We measure the very long chain fatty acids. These are a little different from the very long chain fatty acid. We check for the fatty acid oxidation defects, where we check the where the carbon numbers is less than 20. In this, it is carbon numbers 26, and they're saturated. Very long chain fatty acids are checked by a different method in the blood, and especially C26, which is a fatty acid with 26 carbons, is the most is very important in diagnosing this condition. And you can do the mutation analysis, and the MRI findings can be really helpful. And you have characteristic white matter changes on the brain MRI, typically which precede clinically evident cerebral disease. So what is the treatment? If the child has Addison's disease or adrenal insufficiency because of involvement, you can start steroid replacement if needed. But and for the cerebral form of the disorder, stem cell transplantation is performed, and this has to be typically performed before the onset of the cerebral disease. So what we do is really monitor the child if he's diagnosed by newborn screening or risk. You start monitoring the MRI every 6 months, and the day once the findings are present, at that time, the early findings are present, the stem cell transplantation has to be performed. So just a word about the newborn screening. So many disorders, more than 50 disorders of inborn errors of metabolism can be screened by newborn screening. Analytes can be measured on the dried blood spots. Ideal timing for a newborn screen is about 24 to 48 hours after birth. And false positives, it's important to remember that false positives are inevitable and false negatives can occur. The disorder panels are updated periodically, so I'm not going to give you a list. You need to know what has been tested for at that particular time. But some of the disorder groups that are being tested at this point are galactosemia, where you measure the total galactose and GALT activity, the biotinase deficiency, where you measure the biotinase activity in the dried blood spot, and fatty acid oxidation defects, where you measure the acylcarnitines. The organic acid disorders, again, you measure the acylcarnitines as biomarkers for these conditions. The amino acid disorders, where you check the amino acids, and this includes the urea cycle defects. These three disorders are analyzed simultaneously in a single assay by tandem mass spectrometry. And then, more recently, lysosomal storage disorders are being added. These can also be tested by tandem mass spectrometry, but they are a different assay from the ones that are used for the amino acids and acylcarnitines. So, in summary, it is important while diagnosing the inborn errors of metabolism that you keep a high index of suspicion. With an acute presentation, important to start high-dose dextrose and initial metabolic investigations would be some chemistries, ammonia, lactate, pyruvate, urinary reducing substances, and ketones, plasma amino acids and acyl carnitines, and urinary organic acids. For the more complex disorders, there are very complicated tests that need to be performed, but these are just listed the initial metabolic investigation.